Then you have some set of patients who don't need all clotting factors. They only require factor 8, or they were suffering from efibrinogenemia or hypofibrinogenemia. You don't want to give all clotting factors. For them you can give cryoprecipitate, which is very rich especially in two factors, factor 8 and fibrinogen. Then we can also give platelet transfusions. In which world are we living now? Dengue fever, thrombocytopenia. Surely any viral fever can come depress our bone marrow. Any viral fever can come produce antibodies against our own platelets. ITP it is called, idiopathic thrombocytopenic purpura. Our platelet count can come down. What is the normal platelet count? Between 1.5 to 4 lakhs. If the platelet count is less than 1 lakh, you call it as thrombocytopenia. Once it is less than 20,000, spontaneous bleeding will be there. There will be bleeding into brain, bleeding into conjunctiva, anywhere. So to take care of them, we need to give platelet transfusions, classically. But if you give 1 unit of platelet transfusion, it will raise the platelet count by 10,000. That is the rule. So you want to raise the platelet count to 70,000 from 10,000. How many difference is there? 60,000. So you give 6 units of the PRP, platelet rich products, they are called as PRP, is what need to be given. Now if you give the transfusion, there can be hemolytic transfusion reaction which can occur. Broadly, the hemolytic transfusion reactions are divided into intravascular and extravascular hemolysis. What is intravascular hemolysis? Is also called acute hemolytic reaction. Very serious, very life threatening. What is a very common cause of a mismatched blood transfusion, doctor? It is not Dr. John responsible. It is not Sister Mary responsible. It is the lab technician David responsible. It is the clerical error. Midnight 1 o'clock you asked blood B group. On telephone you told B group. He heard it as A group because he is in the REM sleep. So he gave to the ward boy A group. And you also thought David and Mary will never do wrong and you are Prince John. And there is a high chance of the transfusion going wrong. So as a house surgeon, you need to be obsessive, compulsive, neurotic house surgeon. When under your chairmanship, if there is a transfusion, even if nurse is giving, you have the vicarious liability for taking care of the patient. You need to go check, see that it hardly takes no time, whether there is a correct matching or not. You are cool. You won't do mistake. So it is the ABO mismatch which is responsible for the acute hemolytic reaction, where anti-A, anti-B, antibodies are the ones which basically will activate the complement system if there is a mismatch, and the terminal complement component pathway C9, it will puncture the RBC's membrane. It's called membrane attack complex, and it will lead to hemolysis. So that is the story of acute hemolytic reaction. How does the patient present? If there is a mismatch transfusion, fever, chills, vomiting, flank pain, chest pain, dyspnea, hypovolemic shock, DIC, and because of the hemolysis there is a hemoglobin release, hemoglobinuria, renal shutdown leading to renal failure is the complication. So first thing what you want to do, if you discovered that there is a mismatch, stop the transfusion, replace the fluid, manage the shock, manage the renal failure. Patient will survive. They are the important things to be done. So there is all the story called acute hemolytic reaction, which is often intravascular hemolysis, which is due to ABO mismatch. Then what is extravascular hemolysis? It is also called delayed hemolytic reaction. It is often self-limited. It occurs generally 3 to 4 weeks after the transfusion. And why does it basically occur? It is not due to the ABO mismatch. Generally when we do matching of blood, which groups do we match, doctor? ABO. We don't match for KEL. We don't match for, there are so many blood groups. They are all called minor antigens. If a patient is KEL antigen negative and received a KEL antigen positive blood, which is not KEL matched, that lead to development of extravascular hemolysis, which typically is delayed hemolytic reaction. Why it is called extravascular? The killing of the RBCs does not occur inside the vessel. When the blood passes through the spleen, anti-KEL antibodies are coated on the top of the RBC. That will be recognized by the spleen as a foreign RBC and it will be slaughtered. That is extravascular hemolysis, which occur in the spleen classically. So it is the spleen, liver, bone marrow where extravascular hemolysis typically occur. Even they will present with fever, jaundice, anemia, but generally prognosis is better compared to that of ABO mismatch, which lead to intravascular hemolysis as an acute hemolytic reaction, is what need to be remembered. Now, in this context, doctor, one commonly asked question: you are a surgeon operating the patient, and at the time of surgery there is a transfusion going on. How do you recognize a mismatched transfusion at the time of surgery? Uncontrolled operative bleeding, if it is there, always just incline and check what is the blood group. Is there any mismatch? A mismatched transfusion reflects in the form of a uncontrolled intraoperative bleeding, is what need to be basically remembered. So that's all the story of the various transfusion products which you need to fundamentally remember. Okay, doc. Thalassemias is one topic which you have to be very, very sure and very clear about. In pathology you studied what is thalassemia. What is it? There are 2 alpha chains, 2 beta chains. Improper production of this globin chains, not the heme. Heme is produced normally, porphyrin is normal, iron is incorporated normal into the porphyrin. Heme is okay. Globin का production में problem है, उनको बोलते हैं thalassemia. Now doctor, typically there are alpha chain genes located on the chromosome 16. Alpha is very important because you take any hemoglobin, hemoglobin F, what is the composition? Alpha 2, gamma 2. Then hemoglobin A2, hemoglobin A, Gover's hemoglobin. Everybody will contain alpha chain. Only they differ by virtue of whether they have beta chain or not. If beta chain is there, you call hemoglobin A. If epsilon chain is there, or gamma chain is there, or delta chain is there, you call it as HbF, HbA2, Gover 2, etc., etc. But all of them basically contain alpha chain. Agree, doc? Now tell me, why is this important? Suppose if I have alpha thalassemia, that means my alpha chains are not properly produced. What will happen to my HbA level? कम हो जाएगा, HbA2 कम हो जाएगा, F कम हो जाएगा, Gover 2 कम हो जाएगा, सब कुछ कम हो जाएगा. Everything will decrease if you do electrophoresis. But if I am having beta thalassemia, only HbA get affected, whereas HbA2 will be increased, HbF can increase, Gover 2 can increase. So HbA2 increased, F increased, but with a low HbA ka matlab on electrophoresis it is beta thalassemia. All of them are uniformly decreased means alpha thalassemia. Very basic question, doctor. USMLEs, entrances, everything, if you have basics, if you understood the concepts, no tension. Even if you have cerebral malaria, you will get the first rank, top rank. If you didn't understand, urged yourself, of course there is some mugging aspect. No, we can't deny. See, you may know microcytic, you may know macrocytic, but examiner holds a gun and asks 60 MCV, micro or macro, jaldi bata ke seat le lo. You know, low microcytic is low MCV is microcytic. It is based on MCV, we call microcytic. But that value 80 golden figure should come at that time. अगर वो भूल गए तो जिंदगी बर्बाद हो जाएगा. But such rememberable, muggable, useless, dirty numerical information is secondary in the learning process, let me tell you. First thing is concepts, logic, essentials, real information. That is what you need to basically acquire. Okay, now, so 2 minutes will be out of broadcast.